care organization concept has been around for a small number of years, and it was initially piloted as part of CMS reimbursements and new approaches to innovation. I think there's been a tremendous amount of optimism that this would lead to substantial potential savings in overall expenditures and improvements in quality. The optimism is still there. The reality and the data, however, have not been quite so promising. In the early results, relatively few organizations that have provided ACO services have saved substantial amounts of money. Most have saved very, very little. Well, there's an occasional organization that has demonstrated more substantial savings. On the quality front, so many of the organizations in the early days have been excellent organizations, so their quality benchmarks weren't necessarily raised to a great extent. One could view this from a negative standpoint to say that the optimism may not be really justified. Or one could say that there's a substantial learning process. You need to get the systems in place for ACOs to be so successful, the data systems, the processes. Or you could view it as the incentives aren't strong enough, that still it's a fee-for-service structure within the economic caps and benchmarks. Also, the quality reimbursement bonuses are really rather modest. It's 1 or 2% in terms of the bonus payments for achieving quality, rather than where in the UK some of the bonus structures are 20, 30, 40%. And it is possible that our ACO structures and reimbursements may need to evolve for us to achieve the goals that we all want to achieve of managing cost-appropriate care and achieving great improvements in the quality and outcomes that patients receive.